Okay, I am back. Everybody can hear me?
So,
It's
Yep.
only Mr. Jennings I'm hearing. What about the others?
Yes, I hear you.
I'm here, sir.
Okay. All right, so we're continuing with soft tissues. Going to the burn section. So burns account for approximately 3,400 deaths per year, and this is US statistics. Among the most serious and painful of all injuries, extremely painful. A burn occurs when the body receives more radiant energy than it can absorb. And the source of that energy can come from heat, toxic chemicals, and electricity. Burns always perform always perform a complete assessment to determine whether other serious injuries are present. Right? So burns are terrible injuries, right? And these are injuries that require extensive long-term care, right? And this extensive care is expensive. It's expensive. Now, when you have a burn patient that died very quickly after being burnt or exposed to some form of heat or radiant energy, it is usually from airway problems. So when they die very quickly, it's because their airway was compromised. When they die later on or slowly, it's usually from burn shock, right? So it's because they go into burn shock or sepsis. Always perform a complete assessment to determine whether other serious injuries are present. Children, older patients, and patients with chronic illnesses are more likely to experience shock from burns. Pathophysiology of burns. Burns are soft tissue injuries that are created by the transfer of radiation, thermal or electrical energy. Thermal burns occur when the skin is exposed to temperatures higher than 111 degrees Fahrenheit. Now, the severity of a thermal injury is related directly to the temperature, concentration, the amount of heat energy possessed by an object or substance, and the duration of exposure, right? Now, the greater the heat energy, the deeper the wound. People reflexively limit heat energy and exposure time. However, if this patient is unresponsive, they can't do that, right? They won't be able to do that. I'm gonna backtrack a bit. Okay. Complications of burns. When a person is burned, the skin that acts as a barrier is destroyed, right? So all of the functions of the skin gone as well. So burns create a high risk for infection, right? They are at a very high risk for infection. They can regulate their body temperature. That's hypothermia. There is going to be massive fluid loss. That's hypovolemia. And they can develop septic shock as well. Burns to the airway are of significant importance. So any patient that you suspect has a burnt airway, and you're gonna see signs of that. Patient coughing up mucus with a blackish tint to it, or you can see evidence that the facial ear or nose ears have been burnt. Listen to the patient's voice. Does the voice sound groggy? Can you hear stridor? These are indications that the patient might not be in good shape. Circumferential burns of the chest can compromise breathing. right? So the patient has circumferential burns that can interfere with chest expansion that can cause ventilation problems. Circumferential burns for the extremity can have a tourniquet effect. So if it's the extremities, it can compress the neurovascular bundles, right? So it can compress blood vessels, and it can compress motor nerves and sensory nerve. Now, the severity of a burn depends on the depth, which is how deep the burn goes into the soft tissue, and the extent of the burn, how much of the is burnt. So this is a very important slide. So I'm going to read it again. Burn severity depends on the depth of everybody hearing me now?
Yes, sir.
Yes, sir.
My connection just went for a bit. Right. So the depth is how deep it goes into the soft tissue. The extent is how much of the body surface area is burnt. And these are two things that you will have to determine when you have a patient with burns. So the critical areas involved, or critical areas that you should consider: face, upper airway, hands, feet, genitalia. Patient with pre-existing medical conditions or other injuries, if they get burns, they're going to be critical. A patient younger than 5 or older than 55 with burns, these are critical patients. Now let's look at the depth. Now, depth of the burn, you have superficial, which used to be called first degree burns. Now, superficial is only the top layer of the skin, so that's the epidermal layer. An example of that would be a sunburn. In the pre-hospital setting, we do not calculate or consider superficial burns. We only calculate partial thickness and full thickness. Partial thickness, or which used to be called second degree burns, involve the epidermis and the dermis, right? So it involves the epidermis and some portion of the dermal layer, and you will see blisters present with these patients. In the pre-hospital setting, we will evaluate second degree or partial thickness and full thickness burns. Now, full thickness or third degree is when it goes through all 3 layers, and sometimes it can go through the bone as well, right? So all 3 layers, and this is where you start to see the scarred tissue, block scarred tissue or scarred tissue, right? These patients will require surgical intervention. And here's a picture of that. So this would be superficial or first degree. This would be partial thickness or second degree. And this would be full thickness or third degree. Now the extent of the burns now. This is a very important portion of the slide. So ensure that you understand this portion. Now, because burn patients are at a high risk of developing fluid deficit, they have to get a certain amount of fluid or fluids within a specific time frame, right? And sometimes that fluid has to be initiated, or we have to start give that fluid within the first 2 hours of the patient getting the burn. Now, the fluid that would be administered to this patient is based on their body surface area. So you have a specific formula for that. It's based on their body surface area, a percentage of their body surface area, or the percentage of their body surface area that is burnt. Right? So to estimate the burn severity, you will use either the rule of palm or the rule of 9. All right, so it's either the rule of palm or the rule of 9. The rule of palm is used when the burn is less than 20% of the body surface area or it's irregular. Now, the rule of palm means that the patient palm, not your palm, the patient's palm represents 1%, right? So you can take a paper, mark off the patient's palm, and it's the palm alone, the palm without the fingers, and you will move that over the burns, right? I didn't say put it on the burns. You're moving it up to match up with the burns, and you count the percentage, 1%, 2%, whatever you get would be the percentage of body surface area that is burnt. That's the rule of palm. The rule of 9 assigns values to various parts of the body, right? And the rule of 9 is used when the burn is more than 20% of the body surface area, right? Or a large body surface area is burnt. So extent of burns, excuse me, estimated using the rule of palm or rule of 9s. The proportions differ for infants, children, and adults. What does that mean? So there are certain differences in terms of the numbers, right? Like the numbers for the head of a child, head of an infant, and adult are different. The numbers for the extremities are also different, right? And these are numbers that you have to pay attention to. Now, include only partial thickness and full thickness. I've said this already. We don't count first degree in the pre-hospital setting. We only count the partial thickness or second degree and full thickness or third degree. So let's look at the diagram with the rule of 9. Now look at the diagram. Zoom in on it if you need to on your end. You can zoom in on that. Now look at the adult. So the 9, the entire head for the adult is 9, and that means anterior and posterior it's 9. So if I said that the patient has burn to his face, right? Just the face. Patient has burns to the face. Miss Johnson, how much percentage would that be? So the patient only has facial burns. How much percentage based on the rule of 9?
20%.
Can be 20%. Rowan, the entire head is 9. That's anterior and posterior. It's the face. Rowan, facial burns only, or anterior burns, I should say, to the face. Rowan, what would that percentage be?
Sorry, you're going in and out.
Hello, you hear me, sir?
Yes, I can hear you.
Oh, you said that the entire face is burned because you were going in and out on my end. This
Yes,
kind of.
I said facial burns. What's the percentage if the entire head is 9%?
You hear me, sir?
No, I didn't hear you. All right, he's having some connection problems. Definitely not on my end. Miss Nesbitt, the head is 9, and that's anterior and posterior. The face, the entire face, or entire anterior portion of the head is burnt. What would be the percentage?
4.5%.
It would be 4.5%, so it would be half of the 9%. Now, when it comes to burn questions, right, and I'm not talking about the field aspect of it, talking about the questions that you will see in your exam. It's a maths question, so you have to be very specific. You need to understand what the question is asking, and you need to be specific with your answer, right? Miss Dennis, the adult arm, anterior and posterior, is 9%. The patient has burns to the entire forearm. That's the right forearm. What would be the percentage that's burnt?
4.5.
That would also be 4.5. Good. Miss Jackson, the patient's upper chest and abdomen is 18. The patient's upper back and lower back is also 18. The patient has burns to the upper chest and upper back. Upper chest and upper back. What would be the percentage? If your mic not working, type the answer, Miss Jackson. Ron, patient has burns to the upper chest and upper back. What would be the percentage that's burnt? Having mic issues? Type the answer. Mr. Jennings. Oh, so Miss Jackson says 18%. You agree with that, Mr. Jennings?
Yes, sir.
Okay. You agree with that, Miss Nesbitt?
Yes, sir.
Okay. So yes, Miss Jackson, you are correct. The percentage would be 18%. So again, these questions will be specific as it relates to the field care. It is important because this is the number or numbers that we will use to work out how much fluid the patient will need. And a patient in burn shock needs a lot of fluid. So it's important that you become very familiar with the rule of 9 and the rule of palms and note the differences. Infant head is 18, the child is 12, adult is 9. Lower extremities is 18 for the adult, 16.5 for the child, 13.5 for the infant. Everything else is the same. So note what is different. Right? So when you read the question, is it asking about an adult, a child, or an infant? That is very important. All right, moving forward. I think I spent enough time on that. Now, patient assessment of burns. When you are assessing a burn, it is important to classify the victim's burn. Classification of burns is based on source of the burn, depth of the burn, severity. So again, scene size up. Make sure the scene is safe for you and your crew members, patients, and bystanders. Evaluate the mechanism of injury, determine the type of burn that has been sustained and the MOI involved. Gather information from the patient about the extent of the injury, assess the scene for environmental hazards, how many patients, do you need additional resources, consider potential for other injuries. Let me turn this off. Hold on. All right, I'm just gonna leave it. Begin with a rapid exam. Form a general impression. Remember, the purpose of our primary assessment is to manage immediate and potential life threats, right? That's the purpose of our primary assessment. Form your general impression of the patient and the environment. Look for clues to determine the severity of the injuries and the need for rapid treatment. Be suspicious of the clues that may indicate abuse. Consider the need for manual spinal stabilization or spinal motion restriction. Check for responsiveness using the ABPU scale. Assess airway breathing. Ensure that the patient has a clear and patent airway. Pay close attention to the burn patient's upper airway. Pay close attention, right? Also pay close attention to the lower airway as well. So make sure you're listening to that lungs. Be alert for signs that the patient has inhaled hot gases or vapors, singed facial hair, soot, right? That black color mucus, the patient is coughing it up. That's not a good sign. Soot present in and around the airway. Look for that. Heavy amounts of secretions and frequent coughing may indicate a respiratory burn. Quickly assess for adequate breathing. Inspect and palpate the chest wall for BTLS. Circulation. Assess the pulse for rate and quality. Responsive, peripheral pulse, not responding, central pulse. Determine perfusion based on the patient's skin condition, color, temperature, capillary fill. Control significant bleeding, treat for shock, right? Assess and treat for shock. After your ABCs, what is the patient's GCS? Is it a load and go patient or a stay and play? Do I need to do a rapid scan? Do I need to do a focus? What is your transport decision? Consider rapid transport for a patient who has an airway or breathing problem, significant burn injuries, significant internal bleeding, signs and symptoms of internal bleeding. And once you're working in a system where ALS is available, call for ALS. A burn patient is not a patient to play around with, right? And they might look perfectly fine to you. And I'll give you a little example. There was, I think it was a few years ago, that there was an illegal gas ring in the mountain area, and there was an explosion, and I think about five of those individuals were burnt. And that was a couple years ago. To this day, or to this point, none of those individuals survived. Not one of them is alive. And there were a lot of videos circulating on social media with these guys talking and moving around. But none of them is alive today. They're all dead, right? So do not play around with burn patient. or burn patients. All right. Now, after we have completed the primary assessment, next is your history taking. Investigate the chief complaint. Be alert for signs and symptoms of other injuries due to the MOI. Typical signs of a burn: pain, redness, swelling, blisters, charring, right? And second degree burns can be quite painful. Investigate the chief complaint. Regardless of the type of burn injury, stop the burning process. What does that mean? What do you mean by stop burning process? Ms. Johnson, what do you mean by stop the burning process?
Well,
Hold on. Let me paint a picture before you answer. So I am a burn patient. I appear in front of you. You can see that the clothing I have on, smoke is coming from it. You can see fumes coming from my clothing. So how would you stop the burning process? Go ahead now, Miss Johnson.
roll them on the ground.
I'm not on fire. I have on clothing, and you can see smoke coming from the clothing. What does that suggest to you, Miss Johnson?
It suggests that there is still heat in the clothing, so remove the clothing.
Good. You need to take that clothing off me. How would you get the clothing off? Picking your brain, Miss Johnson. Go ahead. How would you get
Cut
the
it off.
cut it off? Good. So you're gonna have to cut that clothing off. Now you need to look to see if any part of the clothing is sticking to the patient's skin, right? So you're gonna cut around that portion of the clothing. You're not gonna pull it off because it's gonna pull flesh or whatever it's stuck to, right? So any clothing that is stuck to the skin, you're gonna have to leave that, right? Once you remove that clothing that has the heat trapped in it, then you need to cool the burn, right? The next process is to cool the burn. Once you cool the burn, you need to focus on preventing contamination. So you have to use your dressings, or sometimes depending on the size of the burn, you have to use a burn sheet or a burn blanket and treat the patient for shock, right? Good. Yes, Mr. Jennings, go ahead. Go ahead.
So, sir, the when you saying now to cool the burn, right? You would basically wet the dressing in like lukewarm or like almost cold water or something like that, or like I don't know, something like to try and like remove the heat out of the skin or something like that.
No, right? So in my practice, we didn't use wet dressing, right? That can reduce temperature. So you can't have a dressing on a large area of burn. Remember, if a patient has a large burn area, sorry, a large body surface area that's burned, that means a large portion of the skin is gone that regulates body temperature. Would you want a dressing that's cool to be over that large area? If you do that, you're going to induce hypothermia. That's not good for a burn patient. So what I mean by cooling the burn is you're going to run, if it's a thermal burn, you run water in the area for no more than 4 minutes. And that's pipe water. It doesn't have to be cold water. Just normal pipe water on the area once it's a thermal burn for no more than 4 minutes. 4 minutes is sufficient to cool the burn. Now, note that I said cool the burn. I did not say stop pain. Water not gonna stop pain here. So when a patient has a burn, we don't run water on the burn to stop pain. We are cooling the burn, and it takes no more than 4 minutes once it's a thermal burn. The patient will need pain medication for pain. Now, if it's a chemical burn, you're looking at 15 to 20 minutes of running water in the area. So that's what I mean when I say cool the burn. Now, I have seen protocols that use moist dressing for small burns, but that's not something I teach my EMT students, right? Ms. Johnson, had your hand up. What's on your mind?
I was going to ask the same question, sir. You answered it.
Okay, cool. Now, sample history. Along with sample history, ask the following questions. Are you having any difficulty breathing or swallowing? Right? Are you having any pain? Check whether the patient has an emergency medical identification device. After your history, next is secondary. Physical examination. Perform an exam of the entire body. Assess the patient from head to toe, looking for decap BTLS. Make a rough estimate using the rule of nines of the extent of the burnt area. Very important. I already explained why. We need that number to work out how much fluid the patient will get. Determine the classification of the burn, determine the severity of the burn, package a patient for transport. And the sad reality is Jamaica does not have a facility that can deal with severe burns. We don't have it, right? We just don't have it. Now, physical examination continued. Assessment of the respiratory system involves looking, listening, and feeling. Assess the patient's neurologic system, assess the musculoskeletal system, determine an early set of vital signs, right? And you want to do that early. It will help you to know how the patient is tolerating his or her injuries. And as I said to you previously, if they start to show signs of decline early, something is wrong with either their upper airway or their lower airway. If they start to show decline later on, it's either from septic shock or burn shock where the plasma is being lost, right? That is what is going to kill them at that stage. Reassessment. Repeat the primary assessment, reassess the patient vital signs, reassess chief complaint, reevaluate treatment or intervention, stop the burning process, assess and treat breathing, support circulation. Provide rapid transport. Oxygen is mandatory for inhalation burns and large body surface areas. What type of oxygen therapy would we give? Ms. Jackson. If your mic not working, type it. Type the answer. Rowan, what type of oxygen, or I should say, how would you give this patient oxygen? Patient with severe burns, how would you administer oxygen? Especially if they were at risk of airway burns. What type of oxygen would they benefit from? Rowan. Type your answer if your mic not working. Miss Dennis, a patient with severe burns, especially if... Go ahead. Humidified oxygen. So this patient will benefit from humidified oxygen. Awesome. If the patient has signs of hypoperfusion, treat aggressively for shock and provide rapid transport. In Jamaica, all you can do is provide rapid transport. In the States, this patient would need IV access and fluid. Resuscitation would need to be initiated in the field. All right, communication and documentation. Provide hospital personnel with a description of how the burn occurred. Describe the extent of the burn, the amount of body surface area involved, the depth, location. Document if special areas are involved. All right, now let's look at the emergency medical care. Stop the burning process, prevent further injury or additional injury. Thermal burns. So let's look at the different types of burns now and how we manage them. Thermal burns caused by heat. Most commonly, they are caused by scalds or an open flame. A flame burn is very often a deep burn. You have hot liquids which produce scald injuries. Coming in contact with the hot object produces a contact burn. A steam burn can produce a topical scald burn. A flash burn is produced by an explosion. May briefly expose a person to very intense heat. Lightning strikes can cause flash burn. Now, management. Stop the burning source, right? So whatever is causing the burn, make sure that the patient is away from that source. Cool the burn area and remove all jewelry. We have to because there's an inflammatory process that is going to occur. So the fingers, the limbs, they may start to swell up, right? Because of fluid entering a third space or creating a space that should not exist. You may have to use gauze to separate the fingers and the toes because we don't want them sticking together. Increased exposure time will increase damage to the patient. All patients should have a dry dressing applied to maintain body temperature. All patients should have a dry dressing applied to maintain body temperature. This is what I was talking about earlier. To prevent infection and to provide comfort. Inhalation burns can occur when burning takes place in an enclosed space without ventilation. Upper airway damage is often associated with inhalation of superheated gases. Lower airway damage is often associated with inhalation of chemicals and particulate matter. Regardless of whether it was superheated gases or chemicals, pay attention to the patient's airway if you suspect burns. You may encounter severe upper airway swelling, and a patient with airway burns, their airway can close up very, very fast. Very, very fast. Right? You may encounter severe upper airway swelling. You may encounter a patient with severe burns that cause severe upper airway swelling, which requires immediate intervention. We definitely need ALS for this type of patient. Now, the combustion process produces a variety of toxic gases. Carbon monoxide intoxication should be considered whenever a group of people in the same place all report a headache or nausea. Management: first, ensure that you and your crew safe, right? Management: pre-hospital treatment of a patient with suspected hydrogen cyanide poisoning includes decontamination and supportive care. Care for any toxic gas exposure includes recognition, identification, and supportive treatment. Now, for your chemical burns, can occur whenever a toxic substance makes contact with the body, generally caused by strong acids and strong alkalis. And the alkali is worse than the acid. So alkalis are actually far more damaging than the acid, right? Because wherever the acid hits the skin, that's where it will remain in terms of the damage that it causes. Alkalis causes liquid necrosis, right? The eyes are particularly vulnerable. The severity of a burn is directly related to 3 factors, and we're talking about chemical burns now. The type of chemical involved, the concentration of the chemical, and the duration of exposure. Wear appropriate chemical resistant gloves and eye protection. Usually, if it's an industrial setting, they usually have what is called a MSDS document, and this is basically a document that tells you the type of chemicals that are found on that plant and what are the appropriate management. Because you have a lot of chemicals, right? For acid and alkali, what the main treatment is going to be flooding the area with water. That's the main treatment for acid and alkali. You flood the area with water, right? But there are some chemicals that will react with water. So knowing the type of chemical may determine the type of treatment. Now, if it's a chemical that is dry chemicals, you don't put water on it right away. You immediately put water on dry chemical, right? That can cause it to react. So you need to brush that dry chemical off the patient's skin to get it off, right? It's on their clothing. Cut the clothing off, brush all of that dry chemical off the skin, and then you irrigate the area, right? Or flood the area with water. So remove any chemical from the patient. Always brush the dry chemicals off the skin and clothing before flushing with water. Remove the patient's clothing. Management, right? Now for liquid chemicals, immediately begin to flush the burn area with lots of water. Continue flooding the area for 15 to 20 minutes. After the patient says the burning pain has stopped. So this is chemical burns. Do not confuse the management for chemical burns with thermal burns. It's two different managements. If the patient's eye has been burned, hold the eyelid open while flooding the eye. Now, when you're flushing the eyes, you just need to ensure that you don't cause cross-contamination, right? So you don't want the fluid that you're using to irrigate the right eye running into the left eye. We don't want cross-contamination. Now for the electrical burns may be the result of contact with high or low voltage electricity, and in some cases you don't even have to make direct contact with the live wire, right? Because I was electrocuted in the past, and I did not grab that wire. My arm just came close to it, right? And the current arced, and I received burns to my right forearm. For electricity to flow, there must be a complete circuit between the source and the ground. Insulator. Any substance that prevents this circuit, that's an insulator. A conductor is any substance that allows the current to flow. So the insulator blocks the circuit or prevents this circuit. The conductor allows the current to flow. And the human body is a superb conductor of electrical current, right? Our body is perfect for conducting current. Now, the type of electric current, magnitude of the current, and the voltage have effects on the seriousness of the burn. So you can have AC current or alternating current, and you can have direct current. Now, when the current enters the body, it will take either two paths. It's either it will take the path through the tissues and burn up the tissues, will take the path through the blood vessels. If the current gets into the blood vessels, it can end up passing through the heart. And if it passes through the heart, it will disrupt the electrical system within the heart, and the patient can go into cardiac arrest, right? Now, if it's a AC current, if the current from the AC circuit is very strong, it can cause contractions of muscles, and it can be so severe that the patient can get fractures. Now, just like a gunshot wound where you have a point where the bullet enters being small and a point where the bullet leaves being large, is the same concept with electrical burns. The point where the current enters is going to be very small, but where it comes out of the body, you're going to have a large exit, right? Your safety is of particular importance, right? So if you know for sure that that wire is live, do not make any contact or go near to the area until it is safe to do so, right? If you're not trained for that, don't go there. Now, a burn injury appears where the electricity enters and exits the body. Now, two dangers. There may be a large amount of deep tissue damage. So, as I say, it can pass through the tissues and tear them out, right? Or it can pass through the circulatory system. The patient go into cardiac or respiratory arrest from the electric shock. Right, and that's a picture of an electrical burn. Now, management. If indicated, you will start CPR on the patient and apply an AED. Be prepared to defibrillate if necessary. Give supplemental oxygen and monitor the patient closely. Treat soft tissue injuries with dry, sterile dressing. Provide prompt transport. Now, taser injuries. In recent years, law enforcement has increased its use of tasers. Potential complication for patients with underlying disorders. Naturally, if them have a medical problem and you tase them with current, that can cause some complication. Use of a taser has been associated with dysrhythmia. So just like the electrical current, it can cause abnormal cardiac rhythms, and it can cause sudden cardiac arrest. Right? Make sure you have access to an AED when responding to patients who have been exposed to tasers. All right, now radiation burn. I'm not going to go too much into radiation, right? Because the truth is, if you ain't trained, you should not be in the area where the radiation is, right? And what you're looking for really, once a patient has been decontaminated properly, is how long after the exposure did this patient vomit? Or did they vomit any at all? The sooner the patient vomits after being exposed to radiation, the faster that patient will die, right? Within less than an hour, that patient is going to be dead. Right? So once they start to vomit early, it means that all of the cells inside of their body has basically been destroyed at that point. They're not in good shape. So radiation burns. Potential threats include incidents related to the use and transportation of radioactive isotopes, intentionally released radioactivity in terrorist attacks, right? We haven't had that in recent times. You must determine if there has been a radiation exposure, and then whether ongoing exposure continues to exist. Three types. You have alpha, which there is little penetrating energy and it can be easily stopped by the skin. You have beta, which has greater penetrating power but blocked by simple protective clothing. Then you have gamma, which has high penetrating power, so it can easily pass through up the body and solid material, right? Most ionizing radiation accidents involve gamma radiation, and an example of that would be the X-ray. So the X-ray uses gamma radiation. Management, maintain a safe distance. Maintain a safe distance and wait for hazmat team to decontaminate patient. That is the most important management on your part. Make sure you protect yourself. Call for additional resources to remove the patient's clothes. Begin ABCs, treat burns or trauma, irrigate open wounds, right? And these patients are going to have long-term damage if they survive. Notify the emergency department, identify the radioactive source and the length of the patient's exposure to it. Limit your duration of exposure, increase your distance from the source, attempt to place shielding between yourself and the source of gamma radiation. All right, now the last part of the chapter talks about bandages, right? They have your dressings and your bandages, and I've mentioned this before. Dressings go on top of the wounds, bandages secure the dressings. All wounds require bandaging. Splints can help control bleeding and provide firm support for dressing. There are many different types of dressings and bandages, right? Dressings and bandages have three main functions: control bleeding, protect the wound from further damage, right? Prevent contamination and infection of the wound. Most wounds will be covered by universal dressing, conventional 4x4 or 4x8 gauze pads, assorted small adhesive type dressings, and soft self-adherent roller dressings. Universal dressings are ideal for covering large open wounds. Gauze pads are appropriate for small wounds. Adhesive type dressings are useful for minor wounds. Occlusive dressings prevent air and liquids from entering or exiting the wound. Bandages to keep dressings in place during transport. That's the purpose. You use a soft roller bandage, rolls of gauze, triangular bandages, adhesive tape, and self-adherent soft roller bandages are easiest to use. Adhesive tape holds small dressings in place and helps to secure large dressings. Do not use elastic bandages to secure dressings. So we try to avoid using elastic bandages. We don't want to create a tourniquet type effect. Bandage may become a tourniquet and cause further damage. Splints are useful in stabilizing broken extremities, right? Or a dislocated joint. Can be used with dressings to help control bleeding from soft tissue injuries. If a wound continues to bleed despite the use of direct pressure, quickly proceed to use a tourniquet. And that would be the end of your soft tissue injuries, right? Not a complicated chapter. The most complicated portion of the chapter is really burns, right? So you got to pay close attention to your burns. So that's soft tissue, which is going to be common in your trauma patients. Very common injuries. All right, question 1, Miss Jackson, go ahead. If you can use your mic, type the answer. B, that is correct. That is correct, Miss Jackson. Rowan, next question is yours. Number 2. Go ahead. Can you use your mic? Type the answer. B as in boy. Okay. D would be the answer. D would be the answer. So compartment syndrome can occur when a part of the body has been compressed for a prolonged period of time, usually greater than 4 hours. The injured tissue begins to swell, which can impede arterial blood flow and venous return. As a result, the part of the body distal to the compression site becomes hypoxic and metabolic waste products, lactic acid, begin to accumulate. Mr. Jennings, number 3. Go ahead, Mr. Jennings.
It will be A.
A would be correct. Ms. Nesbitt, what effects will application of an ice pack have on a hematoma or cocoa?
Reading. Vasoconstriction bleeding.
Which I didn't get that.
Vasoconstriction and decreased bleeding. D as in dog.
That's correct. Ms. Johnson,
B, sir.
B as in boy.
Yes, sir.
That's correct. Ms. Dennis,
C.
what was that?
C.
Okay. C is correct. Ms. Jackson, number 7. Okay. A is correct, Ms. Jackson. All right. Mr. Jennings, number 8.
gotta say A, sir.
Any full thickness burn? I wouldn't agree with that.
Would you agree with B?
No, I
D?
would agree with D. Mhm. Severe burns include the following: full thickness burns involving the hands, feet, face, airway, or genitalia. Full thickness burns covering more than 10% of the body's total surface area. Partial thickness burns covering more than 30% of the body surface area. Burns involving the respiratory tract, example smoke inhalation, burns complicated by fractures, and burns on patients younger than 5 years or older than 55 years that would otherwise be classified as moderate burns on younger adults. So it's not every full thickness burn is serious. Right?
All right, sir.
Right? So the question is asking which of the following is considered severe? Any full thickness? Not any full thickness. Definitely 5% full thickness with a fracture. Yep, that's a complication. All right, Miss Nesbitt, this is a maths question. So number 9 is a maths question. I think my connection is freezing up. Yeah. Mm,
Sorry, it's C, 36%.
36%. I hear you, but my laptop is, I'm gonna have to log out and come back, but I heard you. Can you hear me now?
Yes, sir.
All right, I am back. I am back in business. Everybody else hearing me?
Yes,
Yes,
sir.
sir.
All right, so before I was booted, I think I heard Miss Nesbitt said that the answer was C, 36, right? And that would not be the case. So using the pediatric rules of 9. Anterior chest account for 9% of the body surface area. The entire anterior trunk, which includes the chest and abdomen, accounts for 18 of the body surface area, and each arm accounts for 9% of the body surface area. Therefore, this child has experienced 27% body surface area burn.
Sure, that's true. I counted the back as well.
Yes, there was a miscalculation on your part. No problem. Work in progress. Miss Johnson, last question. You still with us, Miss Johnson?
Yes, I'm here.
Okay.
I would say C, sir.
Okay. And that would be correct, right? That would be correct. No, I'm having serious challenges with my connection on this side. So this is the plan. All right, so I'm going to be giving you some reading assignments. It's, let me see, 1, 2, 3, 4, 5, 6. All right, so listen carefully, and this is group assignment. I'm putting you in groups. Mr. Jennings, Miss Johnson, so that's Mr. Jennings, Miss Johnson, and Rowan. You three are in a group, right? So Johnson, Jennings, Rowan. That's one group. The rest is the other group. So that's Miss Dennis, Miss Nesbeth, and Miss Jackson. That would be good. Everybody get that?
Yes, sir.
Yes, sir.
So somebody run that by me again. My brain is getting tired. My brain just had a senior moment. So Jennings, who is in your group?
Mr. McKellop and Miss Johnson.
Right, good. So Miss Dennis and Miss Nesbeth and Miss Jackson is the other group. All right, Mr. Jennings, the chapter that you will be responsible for summarizing, your group will be responsible for summarizing and presenting next week is, what's that chapter again? Face and neck, right? So your group will be responsible for presenting face and neck injuries. So you're going to review the chapter, summarize what is important, and you will be teaching me next week and the rest of us, you and your group. You got that?
Yes, sir.
All right. Yes, Miss Johnson.
Next week, which day, sir?
It would be Thursday of next week. Or it can be Tuesday. Which day you think is reasonable?
Thursday, sir.
Well, you can discuss that. Is that a collective agreement or decision?
Yes, it is, sir.
Okay. Okay. Um, Dennis, your group will be responsible for reviewing environmental emergencies, summarizing the chapter, and doing a presentation. Got that?
Yes, sir.
All right, good. So I will only be presenting on, that means I am responsible for 7 trauma chapters. The rest, yeah, 7. The last 2 trauma chapters will be class presentation, and of course, I will be grading you on the presentation. Yes, Miss Nesbitt.
So we are also for Thursday, sir. Both groups will be presenting on Thursday.
That I will allow some flexibility for that, because I don't know if you guys can move at my pace, right? So I think maybe one group on Thursday, the other group on Saturday. Fair enough? Or you want to present on Thursday, Miss Nesbitt? Yes, Miss Dennis.
So I won't be present on Saturday.
I still want my presentation on Saturday, regardless of whether or not you're present. That's when I want it. So whatever needs to be discussed and worked out, work it out. And whatever your input was in the presentation, I need to know, right? Or get evidence of that. But the work continues, right? So in EMS, especially in EMS, I cannot tell my employer that I have church on weekends or on Sundays. When I gotta go to work, I gotta go to work. So
You can choose
work it
where to
out.
work, sir.
Yeah, but I don't have that choice, right? I don't have that luxury. So work it out with your group. If you're not going to be there, let me know what your contribution was, and we will move forward, right? So I understand that you won't be there, but work out something that it can be done, right? I think that's reasonable. All right, so I think we're gonna call it a day. We're gonna call it a day, and I will see you on Saturday. So on Saturday, after that would be the next week Saturday, you know, not this Saturday. So there will be no presentation this Saturday. So I will be covering head and spine and chest. If time allows, abdominal injuries as well. Any questions? I've been looking at the grades for the exam. Anybody completed all 3 yet? I know one person has. Right, I think Miss Jackson has completed all of the exams already. Yes, Mr. Jen.